let's see about the last topic in respiratory system, which is lung tumors. So lung tumors, what is the most common lung tumor? It is usually metastasis only. So metastasis, that too again is going to be most common from the breast cancer. So breast cancer can metastasize to lung easily. And what is the most common benign tumor? Then it will be a pulmonary hamartoma. So what lung cancers can be associated with various risk factors, starting with smoking. Smoking is the most common cause for lung cancers. Other than that, we have seen silicosis and asbestosis caused. So asbestosis was for mesothelioma and lung adenocarcinoma. Silicosis, berylliosis also I mentioned. So all of these pneumoconiosis can cause lung cancer. Other than that, radiation for some other cause, like for some thyroid cancer, if they are having some radiation therapy, so that can also trigger a lung cancer. So coming to the genetics, here again where various genes are being involved for various types of lung cancer. So for a squamous cell cancer of the lung, it is going to be p53 mutation, while in adenocarcinoma it is going to be various other mutations like RAS mutations, ALK, ROS or EGFR mutations. Why is it very important to know the genetics of adenocarcinoma is that we have targeted therapy directed against all of this. So for EGFR, we know erlotinib is a drug which can be used for treating adenocarcinomas. So ALK, ROS and EGFR is the genes which are involved in adenocarcinoma, and it is important because we have targeted therapies for that. And that we always test for any adenocarcinoma, we always test for these three genes. Okay. Then in small cell lung carcinoma, it is going to be L-MYC amplification, L-MYC mutations and amplifications. So MYC, anywhere it comes, it will have a very bad prognosis. So that said, small cell carcinoma is also going to have a worse prognosis. So let's see about the three types of lung tumors in a comparative manner. So in this squamous cell carcinoma and small cell carcinoma, both of it's going to be associated with smoking, but small cell carcinoma is going to be much more associated with smoking than a squamous cell carcinoma. So but adenocarcinoma, it is going to be associated with non-smokers. So passive smokers, the females are more prone. So non-smoking females who are passive smokers, basically they are standing near people who are smoking. So they are going to be exposed and they are prone for developing adenocarcinoma. And adenocarcinoma is now the most common lung cancer. Previously it was squamous cell carcinoma, now it is adenocarcinoma. The location of these tumors are also going to be different. In squamous cell carcinoma and small cell carcinoma, both the S are going to have a central location. So both of us is having C in their names, right? So both of this will have a central location. Mutations I already spoke about, and adenocarcinoma, it will always have a peripheral location. Okay, that is also a difference. Then all of the lung tumors are usually associated with paraneoplastic syndromes, and the most common paraneoplastic syndrome associated with SCC will be hypercalcemia, while in adenocarcinoma it will be thrombophlebitis. That is, any mucin producing adenocarcinomas can result in Trousse's sign, which is migratory thrombophlebitis. Okay, Trousse's syndrome. So that is again adenocarcinoma is related with thrombophlebitis. Then small cell carcinoma is the one which is associated most commonly with paraneoplastic syndromes. And what are the paraneoplastic syndromes associated with small cell carcinoma? It is going to be syndrome of inappropriate ADH secretion and Cushing's syndrome. Out of this, SIADH will be having a much more chances of having. Okay, SIADH chances of developing this be much more in a small cell lung carcinoma. So how do you define these tumors microscopically? Microscopically, squamous cell carcinoma, any squamous cell carcinoma, it is going to have these squamous islands. These squamous cells are polygonal cells. These polygonal cells are all squamous cells having a prominent nucleoli, and it is going to form these keratin pearls. Okay, keratin pearls are seen in squamous cell carcinoma. And then in adenocarcinoma, adeno means glandular formation. So we are going to have this formation of glands infiltrating into the stroma, and these are all dysplastic glands. And nextly, there is a type of adenocarcinoma called as lepidic adenocarcinoma, which was previously called as bronchio or alveolar carcinoma. So now it's termed as lepidic adenocarcinoma. Here it is having a very good prognosis because the tumor cells here will be spreading across the alveolar septae only, okay? Rather than infiltrating into the stroma, they'll grow along the alveolar septae. So all of these alveolar septae are involved by this tumor. So that is having a very good prognosis. And small cell lung carcinoma, here it is going to have it is a neuroendocrine tumor. Small cell carcinoma is a neuroendocrine tumor. So any neuroendocrine tumor will have this kind of salt and pepper chromatin. So the characteristic feature we see in a neuroendocrine tumor will be salt and pepper chromatin. So some stippled kind of chromatin will be present. Along with that, nuclear molding. Nuclear molding is nothing but, if you see in this image, the cells next to each other. So this cell and this cell is there, and when they are next to each other, they are taking a common shape like this. So this cell is like this, and the next cell is taking the shape of the nearby cell. So this kind of appearance is called as nuclear molding, and that again we see in a neuroendocrine tumor. And on cytology, if you see, these cells are going to have the scanned cytoplasm with high NC ratio. Other than that, these cells are going to be very fragile. So when the cytoplasm is broken out, the nuclear material is going to come out. And this extruded nuclear material will go and coat the blood vessels. And this is going to appear dark blue in color, violet to dark blue in color. So this kind of nuclear material coating the vessels is called as Azzopardi effect. So Azzopardi effect is seen in small cell carcinoma, which is a neuroendocrine carcinoma. So electron microscopically also, neuroendocrine carcinomas, any neuroendocrine carcinomas for that matter, it is going to have neurosecretory granules. So these neurosecretory granules can be seen on electron microscopy. So these are the granules which are the neurosecretory granules, which are composed of synaptophysin, chromogranin, bombesin, all of these. So how do we prove that this tumor? So we can use immunohistochemistry. For small cell carcinoma, it is going to be chromogranin, synaptophysin, bombesin, and neuron-specific enolase. Other than that, for adenocarcinoma, we are going to have TTF1, which is specific, which comes positive in adenocarcinoma, along with napsin A. And for any squamous cell carcinoma, be it anywhere in the body, you can use P63 and P40 antibody to detect squamous cell carcinoma. Okay. So the last tumor, which will be carcinoid tumor. So carcinoid tumors are again neuroendocrine tumors which are low grade. So we have two grades in that, which is grade 1 and grade 2. Grade 1 is going to be called as typical carcinoid. Grade 2 is going to be called as atypical carcinoid. So the origin of these cells will be Apud cell, which is amine precursor uptake decarboxylase cells, also called as Kulczycki cells, or endochromaffin-like cells in the intestine. So anywhere in the body you can see carcinoid, most commonly in the GIT, that is ileum especially, more than lung. Okay. And in heart also we had discussed, this carcinoid tumors will elaborate substances like serotonin, which can cause this carcinoid syndrome. So carcinoid syndrome will present with flushing, vasodilatation, diarrhea, flu-like symptoms along with bronchoconstriction. And in heart, we saw that it is going to cause tricuspid regurgitation. So how do you differentiate between grade 1 and grade 2 carcinoids? For a grade 1 carcinoid, we are going to have less mitosis, that is less than 2 mitosis per 2 millimeter square. So previously it was per 10 hyperfield. So now they had changed it to 2 millimeter square. So less than 2 per 2 millimeter square. While in atypical carcinoid, it is going to be 2 to 10 mitosis per 2 millimeter square. And in atypical carcinoid, we can also have necrosis. While necrosis will not be present in typical carcinoid. And urine, you can see elevated levels of urine 5-hydroxy-indole acetic acid excretion. So this is also can be used. So in respiratory system, that is it. So most commonly you'll have to study about this lung tumors, especially many questions come from this lung tumors only. Other than that, chronic obstructive lung diseases, especially the genetics of bronchial asthma, don't forget to read about it.